Hi everyone, my name is Caleb Padilla, and for my advanced anatomy project, I'm going to be comparing an open and laparoscopic approach to full nephrectomies in canines. So in terms of clinical relevance, nephrectomies are relatively uncommon in small animal medicine, but they are utilized to treat a number of unilateral diseases. Examples would be irreversible trauma, primary renal neoplasias, severe hydronephrosis, or a hydroureter, polycystic kidney disease, endoectophymosis, which is the large kidney worm. I was looking through some papers, and medical treatments are typically not effective, so the main treatment of choice for this disease is a full nephrectomy. Before a surgical procedure is conducted, the function of the contralateral kidney must be evaluated. Typically, this is going to be done using scintigraphy or plasma clearance. I talked with Dr. Shaver about BUN and creatinine, and she was telling me that typically they don't do that for these procedures, as using scintigraphy and plasma clearance are more representative of how the kidney is actually functioning. Partial nephrectomies are currently preferred in practice today because they do preserve some sort of renal function. However, full nephrectomies carry less postoperative complications. So a study comparing the two approaches that I was going to talk about in terms of nephrectomies, laparoscopic and open approaches, it determined that there was no difference in mortality and intraoperative complications. Although laparoscopic approaches are associated with longer surgical times, these procedures do reduce hospitalization time, decrease pain management requirements, and improve visibility of anatomical structures. So in terms of the kidney anatomy, so as we know, they do have many functions such as acid base, balance, blood pressure, etc. But overall, the kidney is a pretty simple, like, structured organ. You have the renal capsule. Inside of the renal capsule, deep to the renal capsule is going to be the cortex. Deep to that is going to be the renal medulla, which contains all of these arteries and veins, eventually draining into the renal pelvis, where the renal artery right here, the renal vein, and the ureter insert here, that altogether is the renal hilus. It should be noted that innervation is also occurs through the renal hilus. However, it's not shown in this image. Typical positioning of the kidney. So as you can tell in this image, the right kidney actually is more cranial than the left. However, both of them fall within the first lumbar vertebrae and the fourth lumbar vertebrae. As you can see, blood supply to the kidney is provided by the aorta. So you see that the renal artery branches directly off of the aorta to supply blood to the kidney. It should be noted that the renal vein drains directly into the caudal vena cava. Another note, especially, and this is especially important for intact patients, the testicular vein and ovarian vein drain directly right here. They drain directly into the renal vein. So in order to like in order to ensure that there is proper drainage through these veins, you're going to have to make your ligations distal to those veins, the testicular and ovarian vein, when you're taking out the left kidney. Because as you can see on the right side, the testicular or ovarian vein will actually directly connect to the caudal vena cava. So as you can see, there's the ureter, etc. So in terms of the ureter, it carries the waste that's produced from the kidney to the bladder where it's stored. Again, it goes from the renal hilus and then inserts itself on the dorsal aspect of the bladder neck in an area called the trigone. Blood supply for this area is through the cranial and caudal ureteral arteries. So the cranial ureteral artery, you can see in the image in the top right, it branches directly off of the renal artery right here. So, and then that provides blood supply to the cranial aspect of the ureter. In terms of the caudal ureteral artery, that's typically a ureteral branch off of the vaginal or the prostatic arteries. So as you can see, if you follow it down, kind of goes down, you have the prostatic branch right here, and then you'll get the ureteral branch right there. And it's the same thing in males and females. It's just a change in the name. So in terms of dissection approach for the open ventral midline ciliotomy, so the open approach, an incision from the xiphoid to the pubis will provide adequate visualization of anatomical structures. So a combination of blunt and sharp dissections will assist in identification of the linea alba. Once the structure is identified, the linea alba will be incised to allow access to the peritoneal cavity. If given the opportunity to have retractors, that would be awesome in providing adequate visualization of anatomical structures. It should be noted that the duodenum and small intestines will be in the way, so they need to be displaced medially in order to provide adequate visualization of the kidney. In addition, the right kidney often comes into contact with the right caudate lobe of the liver. So this will also have to be displaced, and it will probably be displaced cranially during the dissection. So once there's adequate visualization by bluntly dissecting the retroperitoneal tissue and detaching the kidney, once there's adequate visualization of the renal hilus and those structures are skeletonized, there will be 2 circumferential ligations on the renal artery, and this will be repeated for the renal vein. But if the renal artery is greater than 3 millimeters in diameter, a transfixation ligature will be placed distal to the 2 circumferential ligations. That way it provides extra security for those vessels. After there's proper ligation, the renal artery will be cut, and again, as I mentioned before, all of this will be repeated with the renal vein. It is important that you ligate the renal artery and renal vein separately, as if they are ligated together, this can result in an arteriovenous fistula. So, that should be avoided. Once that's done, a simple circumferential knot will be used to ligate the ureter, and then distal to that, the ureter can be transected, and the kidney and its associated ureter can be removed from the body. In terms of the transperitoneal laparoscopic approach, I'm going to be doing a modification of the TLU, but I will be using a 3-port technique, and these ports typically are going to be trocars in practice. Typically they are going to be 10 millimeters in size. However, to provide adequate visualization during this project, I am going to make them 1 inch because I don't have the actual trocars to be used for this project, but I will have a telescope that kind of goes in, and I'll talk more about that. So basically, with my cadaver and a right lateral recumbency, a 1-inch incision will be made lateral, about 2 to 3 centimeters lateral to the umbilicus, to provide adequate entry of my laparoscopic telescope. This incision will go through the skin the external abdominal oblique, the internal abdominal oblique, and the transverse abdominis muscle to access the peritoneal space. So that can be seen right here. So this right here is my telescope. Then 2 1-inch incisions will be made at the mid-abdominal level, one caudal to the 13th rib and the other cranial to the pelvic limb. This will allow placement of the simulation trocars, and I will be going through the same tissue as I did with the very first trocar. Once the peritoneal space is accessed, the first things that I will see are going to be the spleen, colon, and stomach. If the stomach's like filled with gas, typically it won't because in a cadaver, but based on having the patient in a right lateral recumbency with minimal traction, these structures should fall medially, providing adequate visualization of the renal structures. This will then, the same thing will happen. The retroperitoneal tissues will be dissected, freeing the renal or the kidney, and then providing access to that renal hilus. Instead of doing circumferential knots and such, I will be using simulated hemoclips, which is commonly used in practice. Typically nowadays, though, to speed things up, they do use vessel sealers and other electrocautery type stuff to, speed up the process. But unfortunately, with a cadaver, I decided to go with the hemoclips. So I will use a 3 hemoclip technique on all the vessels and the ureter. When I dissect or incise the ureter, it will have a ureteral stump. This is typical standard procedure. I haven't seen anything about increase in infections or anything like that with that approach, but that's typically what is done. And then I will insert my simulation laparoscopic retrieval bag to collect the kidney and its associated ureter. And then after that, the procedure is done. So thank you so much for your time. I really appreciate you taking the time to listen to what I'm doing with my project for advanced anatomy. If you have any questions, feel free to ask. I may not know all the answers, but I'd be more than happy to look up any questions that I don't know. Thank you.